Is this better? To thank Sad and Kate for doing this event, you all for coming here, as Kate said. And I am thanking you on behalf of Chancellor Frank and myself. He was at the Big Ten and he's off to LAA Best, but he really told me to say that this is LA's best. When I saw the title of this event, Global Health Research Day, I was just incredibly enthused. I'm going to have to leave you quickly and I won't be able to stay if you talk. I'm so sorry because I'm supposed to be in Seattle, but I decided to move the flight because I really did want to be here with you. So there's no question that higher education for years has been facing a crisis of lack of trust. But now that we see our autonomy threatened, we see our financial risk coming at us, and we see that risk not only in terms of our research, but also, sadly and most frighteningly, possibly in terms of our ability to teach. So the idea of resistance is incredibly important at this moment. Now, arguably, and it's not that we compete over suffering. I don't believe in competing over suffering. There are lots of areas of research and science and health that are suffering, but arguably global health is and has suffered, let's say, the swiftest, deftest challenge of any area in science and in research, both in terms of the blows to our financing and the blows to our institutions. And we're in an especially complex time because we live in LA. So many of our donors and supporters feel strongly, and rightly so, that Los Angeles is part of the global community and that we have to respond to the crisis at home as well as the crises that we see elsewhere in the world. So our task is to, in fact, link these two. Now, what should we be feeling? I outlined several things: uncertainty, fear, a little bit of panic, but I think mostly we should be feeling outrage. Outrage is what is happening. Outrage at the lives that will be lost because we will be able to do much, and that's what I'll speak about, many, many things in our world, but we will not be able to change the lack of medicines to those who need medicines to survive, and we need to be outraged and to mourn that situation and mourn it appropriately without question. But what I wanted to introduce you to a little bit today is an area of work that we started initially for our Lancet Commission on cancer and health systems. And it's an idea that we've been toying with actually for, I would say, over a decade. It's the idea of an economics of hope. I'm actually mistrained as an economist. I'm fully trained as an economist by those who are not necessarily most popular in the economics field, but some of whom have actually won Nobel Prizes for their areas of economics. But within that kind of thinking in economics, which again is not the standard mantra, we've been speaking more and more about the idea of an economics of hope. And it does spin off of work that I did with the late Paul Farmer, who we miss deeply. Sad and I particularly had the opportunity to work with him closely. And he's with us in spirit in so many ways right now and guiding us. But there's no question that we have to miss his voice. But when we started working on cancer in low and middle income countries, the naysayers were just everywhere. And the naysayers were within the global health communities. The leaders who shall be nameless said, "How dare you work on issues of cancer?" And so Paul shared, of course, the story that some of you know, the story of his work with Jim Kim on MDR-TB. And the data that he shared with us, the way he shared that story in the 90s, where the naysayers were, again, among ourselves, the naysayers were at the World Health Organization. The naysayers were saying, no, 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 too expensive, and also we should be doing much less complex things with the poor because they die of poor people's diseases. And for those who know the story, let's say that they borrowed several suitcases of medicines, apparently from the Brigham, and at a time when you could take medicines more easily across borders and out of Brigham without paying for them ever, is my understanding, he took them down to Lima and demonstrated two things. One, that people would actually adhere to treatment, and two, that it could be financed. And lo and behold, prices dropped by over 90% for key MDR-TB medicines. We saw similar for ARVs. We've seen similar in many times, but that's the first message of the economics of hope. We typically are pulled into the short run, short-sighted, I would say, shallow thinking of economics that prices are supposed to be high. Well, they're not necessarily, and that's why they've gone down over time. And there's lots of research that shows that prices are permeable. So the idea that everything costs too much, which is really important in a world where there isn't enough money, is something that's very permanent and is proven to be wrong. But I wanted to give you an example as well from cancer. So think about the HPV vaccine for two reasons. One is that initially, if I'm not wrong, it was about $360 to get someone properly vaccinated and 3 doses. And now, in many parts of the world, it's less than $5 a dose, and it's 1 dose to get a person vaccinated. But also, I looked very closely at the data from Mexico for many years, which is where I do a lot of my work. And in the mid-'80s, the mortality rates were about 16 over 100,000. And I keep thinking of what it must have been like to have been probably, in a room like many rooms here, mostly dominated by male leaders, I have to say, and to say, well, this is before the vaccine. Women, poor women, are going to submit themselves to an invasive, painful intervention called a pap smear, and people are going to decide to use condoms. But that's what happened. And when you look at what happened to the rates of cervical cancer in Mexico, they've dropped between the mid-'80s and about 2010 to half of that, below 8. So what do we learn? Not only did prices drop, no new technology that we thought could never be made largely available, but the naysayers who would have said women, poor women, uneducated, supposedly ignorant women, wouldn't accept this sort of an intervention, they did. So if we were in a room in the 1980s saying that this could happen, people would have said, impossible. But yet it did. And there are stories like this over and over again. And part of that secret sauce is probably the only thing that isn't scarce in global health today, which is patience and patient voice. We have a plethora of patients to help us move through this, and we need that. Now, there's another sort of ingredient to this idea of the economics of hope, which is that we've never measured the benefits properly. So the economics of hope that we see is like a tool for priority setting, but it's also, I think, a tool for giving us hope in this way. A tool for priority setting because, we look at cost-benefit ratios, right? But if the costs are going down over time, and the benefits are broader than we think, which is what I'll share, then many, many things are cost effective where they thought they wouldn't have been, because the cost benefit ratio becomes very different to the way that we have sort of traditionally thought of it. And understanding that plethora of benefits we think is especially important. So, for example, I do a lot of work on breast cancer in women. And we do a lot of advocacy, and I'm constantly harping on the idea that we shouldn't be advocating only for our disease, we shouldn't be advocating only for our breasts, that if we're lucky, we survive this disease, as so far I have, and we will live to get another disease. And then we'll be advocating for that disease as well, in that other part of our body, which is what we should have been doing from the beginning. What does this have to do with the economics of hope? The point is that the big benefit that we get from something like advocacy around a particular disease, in this case breast cancer, is gender equity. We empower women to have voice if we do things right. So when we think about a cost-benefit ratio of an economics of hope, the problem is we never count those benefits. We never count all those supposedly intangibles that we're actually measuring different ways. We never count the value of compassion. We never count the value of working together as a collective. We never count that when you do advocacy on one thing, you actually, if you're doing it right, should be generating advocacy and support for other challenges. And there are examples that maybe sit a little bit closer to home for some of you. I also do a lot of work on access to pain relief medicine. And of course, this started initially with cancer. And when we looked at the incredible lack of pain relief medication in our world, what we call the pain pandemic, we started to think, well, what happened with surgery? And at that point, I was working also with Atul Gawande, and I said, Atul, there's no morphine in the whole world. So how are people doing surgery? And he sent out a survey to some of his colleagues, and they said, women wake up from mastectomies and we give them Tylenol. Now, I don't know how many of you I've had more than one surgery like that. The thought of waking up with Tylenol is unthinkable. The thought of asking surgeons, we have a surgeon in our midst who I just met. There she is. The thought of having your patient wake up without adequate access to any kind of pain medication is almost like forcing you to do torture. Right? But so when we do work on palliative care or cancer to increase access to pain medication, it turns out that we're strengthening surgical platforms for any kind of surgery, but we don't count that when we think about that intervention. So what we're going to advocate for within Economics of Hope is let's count all of the plethora of benefits so that we can think about the value, the real, true value of what we are investing in terms of our work. But also, let's realize that we have to be telling policymakers that if they invest as though the HPV vaccine is going to stay at $360 per woman, they're going to do it wrong. They need to be investing as though the price is going to come down so that the delivery systems are in place. You need to have that forward-looking vision. And that's really what we need here at UCLA and in global health as well. I talked to Sad a little bit last night, and I was thinking a lot about what can we say without sounding insincere. And it's actually very clear, and I can't see all of the people who are online, but I know there are many. And here's my thought. If someone had said to me, okay, you're going to come to UCLA and you're going to start a new cross-campus initiative on global health, I would have said, I need a lot of people and I need resources, and I need those who are working at the Luskin School of Public Affairs, and I need some in engineering, and I need surgeons, and I need SAD, and I need public health, and I need nursing, and I need dentistry. And guess what? You're all here in the room, apparently for the first time. So and some of you online. So instead of saying we don't have the money, the actual fact is that if we're working together as collective, we already have it, right? Because we could never have asked for the funds, even in the perfect world, to get the resources that we have here at UCLA, right? And I'm new here, so I also wanted to share what I think is so special and different. And I've worked in lots of places, and there are two things in particular. One is excellence. There's no question. There's a degree of excellence, quality, depth of rigor and science in the work that's done. But the other is there is a spirit of cooperation that doesn't exist in many places. I haven't seen you all compete with each other or any of those of you who are online. I've seen consistent and constant efforts towards collaboration, which is what we need right now to get at this sort of a collective. So I'm not trying to be pith, and I'm not trying to say yay Bruins, although I am. I am trying to say that new here and at a time that is so difficult in so many ways, and I, live it at home. I live the crises that our leadership, and particularly Chancellor, are working on. So I'm not trying to sound blithe. I am saying that there is a very special gift that we have here, and that in global health, we have all the tools that we need, other than maybe putting all our photos on a website, including the Chancellor's, and using the value of each of us working together, and thanking Sat and Kate for bringing us together in a way that, again, apparently hasn't been done before. And I'll just close by sharing something that the Dean shared with me a few days ago. I was actually saying, what do we say? He did something very true. He said that in a world where so much has disappeared, the baseline has changed. It also means that what we do, what each of us do, is so much more important and so much more necessary. And so I was sort of going to ask each of you, maybe throughout the day or these coming days, to do one thing. Think about 3 things you wanted to do, but you didn't have time to do because you were writing grants or doing what was in your grants, right? Think about those papers. I have a long list of them that I really wanted to write. The people I really wanted to get to know and whose research I felt could be really important to mine, and the collective Zoom calls I wanted to undertake with my colleagues all around the world, but I never had the time. Well, now we have the time. So we have the luxury also thinking, what are the things that we couldn't do before because we were racing for something else, and now we can? I think if we put that together, that kind of productivity, with just understanding who we are, this incredible collective, we are much richer in resources than we perhaps are thinking that we are in this point in time. And we will come out of this having contributed something very, very special to global health without any doubt. And I'm looking forward to doing it with you. So thank you for being here today.
Awesome. Thank you very much, Felicia. Tom, we're going to move right into our keynote speaker. Before you come up, I'm very happy to have Dr. Tom Coates, who many of you know and love, an institution within UCLA Global Health, within the UC Global Health, introduce our keynote speaker. Tom, thank you for joining us.
Thank you, Kate, and thank you very much for that wonderful introduction. And my 25 years at UCLA echo exactly what you said. It's a wonderful spirit of collaboration and can-do, and I look forward to great things in global health coming out of UCLA. In that spirit, I'm really honored to introduce our next speaker, Dr. Gerard Radovosian. For a young man, he has an stellar and interesting and important career. He's born and bred, raised in Los Angeles, graduate of UCLA, and I was talking to him last night. He said physiology and political science. I did that thing that dogs do when they don't quite understand. It's like, really, what a combination. He was thinking of medicine, but then took a very pivotal trip to South Africa in 2004 and realized the importance of public health, which he said he had not heard of before, and public policy in global health. Came back, got his master's degree in public health at Boston University, worked for a while with Physicians for Human Rights, went from there, I want to make sure I get this correct. Oh, he became Deputy Director of Policy at AMFAR, and then worked for Congresswoman Barbara Lee, current mayor of Oakland, as Legislative Director. Went from there to Gilead, where he is Director of Government Affairs. And from there, went to the Biden transition team, working on global health policy. And then finally to the State Department to work with Dr. John Nkengasong as Chief of Staff, Interim Chief of Staff for PEPFAR. So a myriad of experience, and it's hard to believe he's only 40. And he brings a great deal of wisdom. Now, he got his start in doing all of this as a high schooler scooping ice cream at Baskin-Robbins. So the next time you're at Baskin-Robbins getting ice cream, think about the future of the person who's giving you ice cream, because it's going to be stellar. I'm really pleased to introduce Gerard.
Oh. Thanks for that. Wow, what an introduction. Oh yeah, okay. Thank you so much, Tom, for that. I won't correct the age, slightly wrong, but it's okay. We'll go with it. Thank you. Yeah. Well, it's so nice to be back here on campus. I took a walk this morning. I did the Charles Young Loop, and it ignited so many memories I have of my early years in terms of that. The South North Campus difference in fields and the coursework that I was doing, both in poli-sci or physiology. It's inspiring to be a part of today's conversation, given the historical context that Felicia laid out.
Computer just froze. So
computer froze. Okay, yeah. So we're gonna have to keep going. Yeah.
Yeah, and I will get the screen working.
And I'm just grateful to Kate and Tom and Syed and everybody else who created this opportunity to talk about the moment that we're in. I'm not going to have a lot of good news, so I don't want tomatoes thrown at me. But what I want to do is pivot from. I think it's important to review. Let me talk at least with the mic. I think it's important to review what has happened over the last 4 months. It's only been 4 months since the new administration started. And I think through the review of the actions of the administration, I think it's important to then pivot to opportunities, to think differently about how to harness this moment of chaos, this moment of disruption, to think about new partnerships. As Felicia said, maybe a new paper or a new kind of a collaboration that you've wanted to do. And I think what I'll do is talk through some practical ways that we could think about all the different global health actors, including academia, but of course the private sector, multilateral organizations, community-based organizations, all of the myriad of players that work in global health. Something's happening, which is a good sign. Yeah. Should I do full screen? No.
This is like completely frozen. Oh, now it's working.
Oh, good. Okay.
Okay, so we're just going to. Are you okay to see
Taking my
yourself
steam
right?
away. This was my disclaimer slide. Okay, no, it's okay. I'm just kidding. Okay. Well, I already said all this. Yeah. Thank you. So I'm just doing forward.
Yes.
It's or enter. No, not enter. Well, yeah, the point is, things are moving fast in Washington and in our world. And, I was bracing for some news today because the administration's 90-day review, which then got extended to 120 days, this massive foreign aid review that they announced on January 20th, would land either yesterday or today. And so this is kind of the ad that you see at the end of a pharmaceutical commercial on television. Don't hold me accountable for anything that may have changed as the slides came together. And I just sent Vegeta an update this morning because I found a
If you can
couple
just click here.
this era.
Yes.
Okay. All right.
Check out.
Let me see.
It takes. I'm so sorry.
No, it's okay. This is global health. I mean, we work in resource limited settings all the time. Not that UCLA is a resource limited setting. Okay. All right, we're good to go. Yeah. So there's three things I wanted to do. Is really look at just a level set. I know that the global health and policy and structures are not new to this group here, but I think it's important to look at the structures that we were working in and analyze some of the funding mechanisms that govern global health. I wanted to evaluate some of the data that came out during this time period of disruption and chaos, because one of the, I think, interesting moments that we're in, especially in HIV, we saw a lot of modeling and in real life interpretation of some of the policy actions of the administration. I think we need more of that. Of course, we need to gear up for years of that potentially. But I want to go through some of the modeling exercises that myself and others have contributed to, and then I'm going to argue that neuroscience can help us get us the way. Now, I'm not going to be able to answer any neuroscience questions, and I hope there aren't any neuroscientists in the room. But I'm going to argue that a growth mindset will help us cope with some of the challenges that we're facing, and in the moment that we're in. Now, the moment of truth. Okay, there we go. So we all know this. Actually, the reason why I wanted to project this global health architecture slide is because it comes from Julio Frank. Chancellor Frank published this in 2013. It hasn't really changed that much. It's important to understand that global health is all of these players: philanthropy, multilateral organizations, community-based organizations here, academia. All of these players work together in a local context, and they're governed by things that are beyond their control, like trade and investment policies, architecture. That's not architecture, agriculture, security, education, et cetera. And I think that is still very true. And that will, we've seen shocks in the system that's going to change the different intensity levels that these players will play. But it's important to understand that all of these players are important in the current architecture and then moving forward. I wanted to also show that how the United States spends global health funding, and it's very disease specific, as you could see, I think, from this graph. Yeah. 44% of it is HIV, not a surprise. A lion's share of that is the U.S. President's Emergency Plan for PEPFAR, which is a large HIV program, which I'll get into. And I know many of you are beneficiaries of that program and have collaborations because of that program. But our disease, our U.S. global health is very disease specific. And that's the point I want to make by showing this pie chart from the Kaiser Family Foundation. So you're changing or am I changing? Okay, good. Okay, it just takes a minute, so I'm getting used to it. This is the beauty and the beast of the U.S. Organization of Global Health. And as Tom mentioned, I was sitting in that PEPFAR box in the middle of it as chief of staff for the PEPFAR office that reported up to state, which is a bit untraditional. But this is all of the different U.S. government stakeholders that have U.S. global health money, and they have an interest in advancing policy, in shaping administration policy, and having a seat at the table. And one of the first tasks that I had when I went to the State Department, this was right after COVID, the Biden administration had prioritized vaccine donations from Pfizer they had just received, and the goal was to get 300 million doses out to the rest of the world. Every single one of these entities, and there are probably a few more in here that are missing because this slide is already outdated, had to be part of the conversation, had to be part of calls, part of meetings. And when we would fly to country, there'd be a U.S. delegation of maybe 20 global health actors, the USAID, CDC, NIH, FDA. None of us would communicate with each other. And we'd often show up with our counterparts in government, and they'd have one or two, a Ministry of Health official, maybe a deputy. And so that imbalance, I thought reflected so poorly of how U.S. global health is uncoordinated. Now, this slide is a bit is outdated because one of the early actions, as Felicia said, the administration within 7 days dismantled the independent agency of USAID. And so now we're in a process where we're trying to understand how USAID and the components under it, PMI and others, will come under the State Department. But this is something that I want to come back to as we think about what the future could look like. And I know, of course, NIH and FDA are big parts of what fuels research collaborations, many of your portfolios, and is something that we're all watching in terms of its evolution. I mentioned PEPFAR. If you'll indulge me for just 30 seconds, I want to show you a couple PEPFAR slides and talk about the progress we've made in HIV, mostly because a vast majority of global health funding is HIV. This is a photo from the 2003 signing of PEPFAR, which is unthinkable to even, want to imagine that could happen today. Behind President Bush, you have Howard Berman, who was former member of Congress who represented LA and the UCLA area, who was instrumental in PEPFAR's creation. And then you have Congresswoman Barbara Lee, who Tom mentioned was my former boss, of course, Joe Biden at the time, who was just a senator. But this bipartisan force that came together in 2003 to create PEPFAR and is still standing, and don't let anyone tell you that they're not, over 23 years this year, has spent $110 billion in HIV. And that's had progress that has saved lives. Over 20 million people have been put on HIV treatment, and 5 million babies have been born HIV-free. Before 2025, this was the state of the global HIV response, and the truth is we were far off track from the UNAIDS global targets, despite incredible work to increase access to treatment. We still fell short of the 2025 target for treatment, and nearly a quarter of people in the world still don't have access to HIV treatment, even though it's $30, sometimes even less than that for an annual HIV treatment. You have to ask ourselves why after $110 billion. New HIV infections have dramatically come down since the start of PEPFAR, mostly because of partnerships through community-based organizations, academic institutions, of course, all of the work that many of you have also been a part of. But after $110 billion, 25 years of PEPFAR investments, 1.3 million people still get HIV infected, including 39,000 in the United States. I love to show this because people say, oh, Jawahar, you've worked in HIV, you've gotten so much money, PEPFAR has received so much money. We've got to pivot to other areas. And of course, I agree, we have to pivot to other areas. But this is, as of 2023, all of the new HIV infections that are still occurring despite our best efforts. We're seeing a dramatic reduction in sub-Saharan Africa, mostly because of PEPFAR and the work of the Global Fund and other partners. But there is active epidemic expansion in 3 other regions of the world, including in Latin America, just to the south of us, in Central Asia and Eastern Europe, and in Middle East and North Africa. And there are a number of reasons for that. Well, I won't talk about it today, but policy barriers, equity issues, criminalization of key populations, women that are still disproportionately burdened by HIV. It's a long, long list, but the work is unfinished. I've talked a lot about this already, but this just gives you a snapshot of what PEPFAR, of what the world looked like before PEPFAR. And the point I wanted to make here is that not only is it saving lives and putting people on treatment, but it actually had economic benefits as well. We saw GDP was declining in the early 2000s, at around the time that Tom said that I went to South Africa. And we've seen, because of PEPFAR, including with World Bank estimates, that GDP has actually gone up because of the work that PEPFAR has done. All right, so I wanted to lay that foundation because I'll come back to PEPFAR as it relates to everything else that's happening in global health. One of the things I want to argue is that we're in a post-COVID era as it relates to policy. And if you thought that policy and bipartisanship could not be at its lowest moment, one of the things that I witnessed firsthand is that the post-COVID era really created this sourness that around public health issues, around global health issues, and anything that came close to these issues in Congress. A lot of this fueled from misinformation, of course, the Trump administration's handling of COVID, questions around the origins of the virus, which are still lingering. But the point I want to make is that has really soured in some really, really low ways the work that is happening in Congress around any sort of bipartisanship for anything. So PEPFAR and many other things, but this is just one example that shows that PEPFAR got a 1-year reauthorization in 2024 for the first time ever. It had received 3 5-year reauthorizations. PEPFAR was lucky, many will argue, that they got a 1-year reauthorization, and it's true that they did, that they were lucky. But the post-COVID political dynamics are very much alive. They fuel this administration's policy priorities. They fuel this administration's actions to disrupt and to disrupt HIV and all global health programs, family planning programs as well. And so that's something that I think it's important for us to understand and to anticipate. So in summary, in this first section, we've talked about how global health is multi-sectoral. Of course, it involves actors at all these different levels. HIV is central in the sense that it's a vast majority of the portfolio, even after all the destruction that they've cut. They've cut some $12 billion in global health, which I'll show you. HIV still remains a big portion of that. U.S. global health efforts are fragmented, spanning multiple agencies, and the progress is real, but very fragile. We continue to be off track globally on HIV, with epidemic expansion occurring, as I mentioned, and that PEPFAR's reauthorization, I think, foreshadowed some of the turbulence that came on January 20th and beyond. So now this is the doom and gloom part. Just close your eyes and ears if you need to, but I think it's important to understand all the things that have happened between January 20 and May 20th, which was just yesterday. This is a timeline slide that I update maybe once a week because so much happens in global health and development. But just to review, on January 20th, the administration announced this executive order to review global health. At the time, I spoke to a reporter and I said, that seems reasonable. Any administration wants to review funding. The executive order didn't say new funding. It said existing funding. It wouldn't stop future funding. And so I actually told the reporter that this is reasonable. Every administration does it. I was part of the transition team that when the Biden administration came in, we had a similar posture, not technically an executive order. But with what transpired just a few days later is something dramatically different, which was a complete stop order of all foreign aid programs that we saw on January 24th. And that's when the axe really came down. That's what created that shock, where programs were told, paper down, pencils down, close your clinics, nothing is moving forward. So not only not only future obligations and funding, but current programs. And that stuck around for at least 7 to 10 days until the State Department was able to orchestrate some kind of waiver program, which was messy and haphazard, where they created waivers for different life-saving programs that they called it. PEPFAR and a few other programs were able to secure a limited waiver for programs to continue, but the damage had already been done. And the damage continues, which I'll discuss in a second. Around that same time, on February 7, 17 days since the administration took over, you saw the letters come off of the USAID building, which I live just down the street from. So this is the kind of moment we're in today. I was expecting on May 20th, when the administration said we'll get an understanding of how the foreign aid review is going to conclude. It's important because many programs are operating in a waiver posture, which is still roughly about 40 to 50% of their current programming, and we have to understand what's going to continue, what's not going to continue. So any day now we'll get some kind of formalization of the foreign aid review. Maybe we will, maybe we won't. We'll see. Secretary Rubio also announced a massive reorganization of the State Department that has implications for all of this. As I mentioned, USAID is being brought into the State Department. All of the global health programs are being integrated into one global health initiative. I actually think I'll argue in a few slides that this could be an opportunity. But those authorities and the manner in which they've done it is extremely questionable, and which Congress is pushing on now. Actually, Secretary Rubio was on the Hill yesterday, and he will be today too, answering questions about the proposed reorganization, which will take place on July 1. I mentioned that there are one of the, I think as a student and a scientist of data, we saw a proliferation of different research teams come together to produce the kind of analyses of policies that I think is really important and that we're going to need to continue, as I mentioned. One of these studies was from Avalier and John Stover, and by the way, we'll circulate these slides, and I have the references at the end. They showed what would happen if PEPFAR completely went away, and you'll see the dramatic spike in AIDS-related deaths and orphans due to AIDS. Another study came from my research group. We looked at what the implications would be of a 90-day pause, which is what they initially announced on January 20th, and we showed that 100,000 lives would be lost just in 1 year of PEPFAR. 100,000 lives would be lost in 1 year just by a 90-day pause. And we were one of the first to get, I think, a peer review publication, I'm told, around this. This is, hold on a second. I just went ahead like 12 slides. I don't know what happened. There we go. Okay. I wanted to show this modeling from Imperial College and McGill University because it showed they looked at 3 countries in West Africa. This one from Cote d'Ivoire I wanted to spotlight because the point here is that even, as you could see, a full PEPFAR withdrawal would lead to a massive spike in new infections. But even with those more modulated policy provisions, whether it's a 3-month pause, but a regressive start of treatment, or a 3-month pause, and only key population programming was continued to be not authorized to continue. That green line is what the impact of what it's already happening would be on our HIV programs, and I think that's important. And I think the point here to make is that the damage is already done, and I'd already argued that we were far off track from the global HIV targets, and so the work continues. I mentioned that PEPFAR received a waiver. This was a over 20-page document, a very specific set of instructions from the State Department to PEPFAR that said, treatment programs can continue, and PEPFAR has a pretty expansive definition of what treatment and care means. And so treatment continuation, not expansion, continues within HIV programs. So a lot of that has slowly turned back on, although with lots of hiccups along the way. Hiccups is the word that Secretary Rubio used yesterday. What I think was more dramatic in this waiver is what they explicitly said cannot continue. So HIV prevention, they have prohibited as part of the PEPFAR waiver, except for pregnant and breastfeeding women. Key population programming, equity programming, LGBTQ programming related to HIV have all been paused since January 20th. And they explicitly said that even if someone who was one of those populations that I've just said were unauthorized to continue, even if they had come to receive their PEPFAR prep from their PEPFAR program, whether it's oral prep or injection from cabotegravir, which you need multiples of, they cannot come back to get to fill their dose. So a lot of people have concerns around resistance developing. And PEPFAR, the reason why that's important is because PEPFAR covers 90% of global PrEP coverage as of 2024. And so when PEPFAR programming is not authorized around HIV prevention and PrEP, this modeling from the HIV synthesis group shows what happens to HIV incidence. So a lot of work to do. And as Felicia said, we're entering an era where there'll be a lot more work around HIV. So students, when I talk to younger global health professionals, I talk about there being a growth industry in public health because of the damage and the work that needs to be done, not only in HIV but in global health. I mentioned key populations. I want to spotlight this from this modeling study, looking at key populations in sub-Saharan Africa. There's been no programming for the last 4 months since January 20th. Key populations are disproportionately impacted by HIV, as you all know. And this modeling shows, this is from Peter Vickerman's group, the spike in HIV infections among female sex workers, MSM, transgender individuals. These are the people that are most vulnerable to HIV, most marginalized in communities, and most reliant on U.S. government support to access their care and treatment services. Something happening? No. Okay. So Secretary Rubio yesterday said, I don't know why the HIV community is overreacting. PEPFAR has a waiver. He literally said this. PEPFAR has a waiver. 85% of programs have been authorized to continue, which is not accurate. People should just do their work, is what he said. I'm paraphrasing a little bit, but one of the issues with the waiver issue, which for PEPFAR, is that a vast majority of PEPFAR funding is through USAID. And as you could see here from this graph, 60% of PEPFAR funding comes from USAID. USAID, as I showed in that timeline, was completely dismantled at the same time as the PEPFAR waiver was being created and PEPFAR programs were told that they can continue. So what we saw break down in this time period was finance payment systems through the Treasury Department, other kinds of cooperative agreements that USAID had for HIV treatment to continue. So even the waiver was on a piece of paper, it was just as worthless as a piece of paper, basically. And so the vast majority of programs are still having issues with payment systems, with partnerships being restored, and a lot of work still has to happen for these programs to come back online. 37% roughly is HHS, of which CDC is a big part. And as you may have noticed, the administration has already started with some reorganization within CDC as well, including the termination of the Maternal Child Health Division within the HIV Bureau. So the devastation continues. We're almost done with this time period, so don't worry. One of the other things that happened on top of all of this was that PEPFAR's reauthorization expired on March 25. Now, this doesn't mean that the PEPFAR program goes away, which some people think it does. The PEPFAR and a lot of global health programming is authorized under permanent legislation. So the Congress, so long as they appropriate the funding, these programs can continue. These days, we have to add another caveat, which is so long as the administration spends the funding, right? But PEPFAR currently is unauthorized. There are a number of very specific wonky policy things that will be unable to continue unless program is reauthorized. And I think chief among them is this earmark for care and treatment, which is 50%, 10% for orphans and vulnerable children, a few other wonky things related to how the program is run, the oversight with the Global Fund commitment. And I think what's important is that without a PEPFAR reauthorization, this gives the administration a lot more flexibility to change, to cut, to move things around. And it's something that many of us in the HIV space are watching. And we're in unprecedented territory at this point. This is a slide that I kind of previewed earlier where is a summary from Kaiser Family Foundation about everything that's happened in terms of the global health funding. And when I look at this slide, it really brings home the message that global health, we're not having global health back the way it was before. Global health is forever changed in the sense that vast majority of these programs are cut. Within their current actions, 12.7 billion have been terminated, including 86% of maternal child health programs, 86% of nutrition programs, TB, HIV, malaria, all across the board, including the President's Malaria Initiative. So I think we can all agree that global health is not the same. And I think we have to live with that in thinking about the future and where all of this is going. Now, this is all funding that has already been obligated by Congress in fiscal year 2025. The administration has a number of proposed cuts for FY26, which I'll show you in a second. I wanted to mention NIH because the NIH component is large in the U.S. global health architecture. It's big for research collaborations and for clinical trials that many of us are part of. And this from Senator Sanders' report from a couple of weeks ago just shows a dramatic drop in NIH funding, 1.9 billion, if I'm not mistaken, just in research collaborations, disproportionately impacting medical schools and hospitals. And then, of course, this directive around foreign subs. And I think this will be a big hit to research collaborations, which and it's also an opportunity, I think, to think about what that could mean for the new kinds of partnerships and the new ways of working together with different research enterprises across the world. NIH did not prohibit direct funding to foreign organizations, but we know that's complicated and hopefully many of them will be able to continue their funding. But the NIH piece of this is important. So we've now covered the damage, the disruption, the chaos of what's already happened based on funding that the Congress had appropriated before. In terms of the other moving piece that we have to be aware of and anticipate is what Congress is doing now in response to the president's budget, which is the FY26 process, which you know from your work starts in October. Yeah, I think the LA Times graphic here shows it nicely who the winners and losers are. And of course, chief among the losers is continues to be USAID, which they've used as a catch-all phrase for global health and foreign aid in general. But when you try to apply some sense to understand the themes across the president's budget and how that's going to inform more cuts coming down the pike for FY26, they're really around these 5 themes. One, that they're ideologically driven. So programs that are focused around equity, LGBTQ rights or LGBTQ health services, reproductive health, these have all been virtually eliminated. There's a narrower definition of public health, which I think is interesting to unpack. Even though they say they're more focused on chronic disease management, the budget priorities reflect an opposite posture. Defunding of major environmental health programs and that will impact public health, of course, behavioral health and social determinants of health. All of these things are cut from the budget. There are a number of restructuring proposals, including at NIH and including within CDC, that are labeled as cost-cutting measures, but they're indiscriminate in the way they're moving these boxes, and they will have implications because jobs are being lost and program lines are being combined. And then, of course, there's elimination of equity-focused initiatives, which we've already talked about. And then there's a de-emphasis on prevention. When you look at public health programs, and in particular HIV programs, we've seen this on the global side as well. They're okay with keeping people on treatment, but when it relates to HIV prevention, globally or domestically, that's where we see the largest cuts. In the domestic HIV program, the Ryan White program, for the most part in the president's budget was maintained, actually. It got an $80 million cut, something I never thought I'd say. They only got an $80 million cut, but this is the kind of context that we're working in. But even the president's 2019 announced Ending the HIV Epidemic Initiative, which President Trump announced himself, which is largely focused on HIV prevention, completely eliminated, even in his own budget. So I wanted to talk about what happened, what's coming. This budget process is playing out as we speak. This will have some kind of resolution towards the next, I would say by the summertime, and by the time we feel it in terms of grants, in terms of further reductions, it's going to be, I would say, by the end of the year. So the point here is that more cuts are coming. Quickly summarize this, and I'll talk fast because we want to get to the good stuff. Massive, the abrupt pause of PEPFAR, but also USAID, PMI, led to widespread service disruptions. People lost access to treatment. Roughly about a third of people, according to an analysis by Health Gaps, lost their access to HIV treatment. I'm not even talking about prevention, treatment. So think about what that means for resistance development. Since January 20th, 770 global health awards were terminated, totaling $12.7 billion, as I've already showed. The limited PEPFAR waiver led to a small return to access, but still massively disruptive because of PEPFAR's interagency mechanism. The waiver leaves out HIV prevention, leaves out important work for key population programming. PEPFAR's authorization expired. We've talked about the historic loss of funding for NIH, $1.9 billion, and more cuts are coming. And that is the realistic prospect for what to expect moving forward. I told you this was all I had to just get that out of the way. So now, am I doing okay on time? 10 or 9? Okay, so let me go through a few more slides. What I wanted to do, I love showing this slide when I talk to students because this feels like global health in some ways. We've landed on Mars. The structures are unrecognizable, and we're trying to understand what's still standing, what partnerships still exist, what clinics are still open, who's trying to seek care. But this is what global health feels like if you're in the field right now. What I want to do is talk about how we can manage and cope with the changes that have occurred and that are forthcoming, and be more proactive in being solution oriented. And I mentioned this brief neuroscience reference, which I wanted to make, is this work that Carol Dweck has led, which was around this fixed mindset versus a growth mindset. The fixed mindset is that people who they believe in, their qualities are carved in stone. They tend to be rigid in the way they think. They hold on to the status quo. And she argues that the growth mindset is an opportunity for people to believe that their qualities can be developed and their learning can be enhanced through their experiences and their life's work. This field came mostly from this work mostly emanated from her work in education, and in the way education teaches students to learn. But I thought it would be interesting to kind of think about this growth mindset in the context of global health and foreign assistance, and what it could look like if we all try to adopt a growth mindset for global health reform. And so what I wanted to do is basically talk about if we try to rewire our minds for reform, we start looking for new opportunities. If we manifest that reform is coming, that change is happening around us, we look at the world differently, and it's because mindset shapes our eyesight, and really it allows us to think about new kinds of partnerships and new kinds of ways of restructuring aid, doing collaborations differently, bringing people to the table that were not necessarily at the table before. But I also wanted to pause here and say this. Felicia mentioned how important resistance is. And this does not negate the active resistance that continues to happen, that needs to happen, the litigations that are ongoing. I think there are 14 cases now in front of different various lawsuits around some of the proposed actions. All that's really important, and I think is separate from what I'm talking about here. But it's important to also mention that active resistance is part of thinking about the moment that we're in. So when I started applying this growth mindset to global health, I started using my own experience being that COVID coordinator at the State Department, working across, as I said, 17 agencies, being the chief of staff of PEPFAR, witnessing the interagency, lack of collaboration, the interagency competition over resources, and how that played out at the country level, and in some ways, embarrassing ways in front of ministry officials. When you start looking at some of those things, there are a number of ways that global health needs to reform. Others have written about this, of course, but metrics are still outdated. Systems are built around what donor priorities should be, what members of Congress and the administration say should be global health priorities. Our HIV programming in particular, but all global health programming remains siloed for many reasons, and there's no incentive for these programs to collaborate at the country level. Why not? We have to change it. There's resistance to risk taking, which impacts the way we work with the private sector, the way we take new things, we take on new initiatives and innovative partnerships, knowing that we might fail, but if we fail, let's fail fast. And there's a lot of control based on the funding that has limited the kinds of partnerships that global health entities can actually have with real community-based organizations who are at the front lines of the people that we're trying to serve. There are a number of other issues, but just gives a snapshot of what some of the challenges are in global health, which are, I believe, are opportunities. This paper just came out a couple months ago from Wyeth and colleagues. They called the PEPFAR model the path dependency model. And I like it. It's not a popular piece to tell. It's not a popular story to tell among HIV people, but they showed how PEPFAR's disease-specific model really unintentionally locked countries into this reliance on donor support, whether it's parallel procurement mechanisms for ARVs, parallel funding mechanisms for healthcare workers in these countries, and over time, governments created universal health schemes, UHC programs, that left HIV outside of their insurance schemes in many of these countries. And Malawi is a great example of this. You ask the government, why is the UHC scheme, why does it not include HIV? Why is it not integrated into HIV? And the answer is, well, there's a PEPFAR program. How does that make sense in 2025? And so this is something that I think is, for me, an opportunity to think about how we can be more integrated in global health programming. Just some applications of what a growth mindset can do. I've talked a little bit about this, but just for the sake of time, and I included a link to a paper that I wrote on this. We applied the growth mindset theory to reforming PEPFAR, what that could look like. It's a paper that we published recently with CSIS around how co-financing can be structured in aggressive ways, but in ways that understand what countries' economic priorities are, programmatic priorities are. We talked about how we should be including disruptors in programs like long-acting PrEP, and then also how the administration can rebrand PEPFAR and the HIV work. So I invite you to take a look at that CSIS paper. Now I want to do the same for all the other, and we'll kind of end on this, all the other entities that I started with in the Julio Frank slide, foreign assistance, academic partnerships, private sector, international organizations, what it means for philanthropy and what it means for jobs, which many of us are thinking about, and students in particular are thinking about. So how do I see foreign aid, global health shifting? There's going to be a big focus on sustainability, of course, transitioning away from this, from disease-specific programs to self-reliance. The administration, and in particular the USAID initiative under the previous administration, talked a lot about self-reliance. There's an emergence of regional institutions, which started before this current moment, of course, but the Africa CDC in particular played a massively leadership role on the COVID-19 response. I think we're going to see more partnerships between academic institutions and regional organizations like this. We're in the process of signing one now with Duke University. There's a shift from emergency aid to long-term system investments, and I think many of us have called for compact models that MCC embodies in terms of the way it really partners with countries and understanding what their priorities are. Talk about how aid has to be shock absorbent and resilient because the next shocks are coming. The FY27 budget is something that we'll have to worry about next year, and someone will be up here to talk to you about that next year. But what does that mean for aid now in terms of being absorbent of some of the shocks that are still going to come? And then I think this big unknown is how USAID will be integrated into the State Department. All global health programming will be integrated into the State Department. And if you said this out loud 5 months ago, people would think you're crazy. What is a State Department, a foreign entity, foreign, diplomacy organization, what business do they have in global health? But that is something that comes with a lot of risk. I would argue some opportunity, but that trust building is so important because of all the devastation that's occurred. So I think these are some of the themes. I want to hear from you also if you agree and what you would add to these. But this is how I see foreign assistance shifting. For academic institutions, and I'd love feedback on this as well, there's obviously going to be less money for research and collaborations, but what could that mean for new funding partnerships, new funding models that we've been hesitant to explore? We have to embed civic education in education and curriculum. I ran for Congress. Tom, you forgot to mention that I ran for Congress. That was the hardest thing I've done in the last 20 jobs that I've had, as you mentioned. And one of the shocks for me, and I ran for Congress here in Los Angeles, was how uneducated people were, even in LA, where we think we're eclectic, we think we're knowledgeable, how uneducated people are about about how, voting happens, when voting has to occur, branches of government. I'm generalizing a little bit, but and the importance of Congress. When I was knocking doors, and I knocked on 35,000 doors, first question I got was, why are you running for Congress? What a waste of time. That institution is broken. That was and people felt that, and for good reason. But I just told you all the reasons why Congress is important, right? And so I think we need a reimagination of civic education and all kinds of programs that we do, even as global health practitioners. We have to know how Congress works. We have to know what the instruments of power are and how we can influence it. We have to be more interdisciplinary in our training, thinking about AI, of course, climate. That's what we're doing today, which I'm really excited about. John, I had art in here, as you can see, that was for you. And then we have to look at ways that we could strengthen the autonomy of regional organizations even more and find new ways of partnering if they want to partner with us, right? And I think that's a key question that we have to ask ourselves. We're entering an era of a lot of disinformation. Disinformation that we can't control. I was just told yesterday that somebody made a podcast using my voice, which is just unbelievable to think about. Yeah. And so how do we counter this? How do we manage the misinformation that's going to exist in public health as we talk about new innovations, vaccines, HIV prevention options, et cetera? And I think that we all have to be more multi-sectoral in the way we think and the kinds of grants that we apply for, the people that we bring to the table, including outside of our comfort zones, like working with private sector, like working with media and legislators as well. Let me talk about the private sector. Tom mentioned I worked there for 7 years. One of the first things they teach you in public health is how bad the private sector is. They're profit-driven, conflict of interest. I'm not arguing with those things, and that's true. But the private sector is also a big deliverer of healthcare in many settings where we operate. And so I think this moment of shock is an opportunity to think about how to bring the private sector closer. Massive expectations on the private sector to fill the gaps that have been created by the cuts to global health, the cuts to the World Health Organization, which we haven't even talked about, all the other UN agencies that have received cuts because of the actions of the administration. Everyone wants the private sector to fill the void that's been created. They can't do it all, but they have a role to play, of course. They also have some influence in preserving what we hold as our values for human rights, for LGBTQ rights, for equity. There's an interesting shift that we're seeing in intellectual property law as new innovations come online. We see there's an over-reliance on the medicines patent pool. Some have been criticized for not relying on the medicines patent pool, but what does it mean when you have a new HIV prevention drug and you're licensing it to Sub-Saharan Africa, but there's no one in Sub-Saharan Africa paying for HIV prevention? What could that mean in terms of the way private sector can act? Will they stop new innovations if there's not a global health payer? That's something very scary to think about in terms of more innovations. AI, of course. I want to just mention this piece about consumer empowerment. We're in this Ozempic phase where you can get Ozempic in 3 clicks now, delivered to your home. Of course, you have to be able to afford it. But why can't HIV prevention be more like Ozempic? And there's a lot of new platforms now that are direct-to-consumer platforms. And I think it's interesting that Novo Nordisk, which is the manufacturer of Ozempic, worked with one of those online platforms called Him and Her. I don't know if you use it. I use it for my HIV prevention, for my hair loss pills. But why can't we do that for HIV prevention as well? and I think this is an area where companies like Gilead, like Merck, like Johnson & Johnson that have these new innovations in HIV and maybe in malaria, we're going to see a shift to this direct to consumer where you can buy directly from the company or through one of these online platforms. There is one example of this in HIV called Mister, where you can get your oral PrEP pills after a few clicks. You don't never have to see a healthcare provider. You click a few buttons, they'll mail you an HIV test, an STD test, and then PrEP is delivered to your door within 5 to 7 days. We need more of this in healthcare. And by the way, this is not just in the United States. There's really great examples happening across Asia and the Philippines in particular, as well as in Kenya, South Africa, and other places. More of this has to be the future. Lots of change for international organizations. I showed you that crazy chart about what U.S. global health architecture looks like. This is the global health architecture for all international organizations. Hard to make sense of any of it, and it's exactly the mechanism that failed to deliver on vaccine equity, which we all desperately needed when COVID came onto the scene. So what is that? We're seeing big shifts now because of some of the funding cuts to WHO. They announced a major restructuring this past week. Shutting down a number of their departments, consolidating different departments. I think they went from 8 departments down to 5. They're shifting away from Geneva to the field. UNAIDS is cutting 50% of its budget. So I think there'll be these have implications for the kinds of collaborations that we can have. And there's a reliant, they're being what am I trying to say? They're being forced to be more agile and more focused on their original mandates around normative guidelines rather than service delivery. We saw WHO in particular get pushed in a lot of this emergency response, and they're looking for ways to kind of come back from that and recover. The U.S. withdrew from the WHO on January 20th. It was the second thing the president did on that day, and that has a $500 million cut for the budget of WHO. So massive, massive implications. I think we're going to see mergers in different global health organizations, including Gavi and Global Fund. And I think that could create new opportunities for coordinated collaboration at the country level for some of these funding streams to come together. I'm going to end here with just the philanthropy piece, which is obviously massive. They're another sector that is under pressure to fill the gaps that we're in. Last week, I think it was last week or the week before, Bill Gates said that he's ramping down the Gates Foundation's work. They're doubling the money, but they're going to close the doors in 20 years. And one of the things that he also said, which I thought was interesting, he said there'll be a proliferation of other billionaires who will continue this work. Well, these are the 50 most richest people in the world. So one of these, maybe hopefully a couple others, will fund some of the global health work. But we need to start thinking about who they are, what they care about, how we can appeal to them and bring them closer to our work. The other reason why I love this graph is because you see the yellow circle is humanitarian aid. And look how humanitarian aid compares to the 50 richest people in the world. Philanthropy is under pressure to stand firm on their values of human rights and DEI, just like the private sector is. And there's a reliance that we're seeing on them to hold on to their historic investments they've made through their programming, through their community partnerships. So there's not a lot of room for new kinds of partnerships, but we have to think about how we can take advantage of the monies that they continue to have and the important role that they'll continue to play. Then the last slide is just around jobs. I think there'll be a demand for jobs in global health. It might take a couple years in terms of some of the difficult moves that are happening now in global health, but there'll be less emphasis on DC, New York, Geneva. There'll be more of a push. This is what I tell students in terms of where global health jobs will be created. You have to understand how policy and advocacy come together. You have to be diplomatic in the way you engage. There's I think a shift that we're seeing to localization and implementation science, and I don't say that because that's what I studied, but I think that we're seeing more implementation science focused work. Most of the foreign aid jobs that were cut, according to an analysis from Devex, show that people were moving to jobs in climate and AI and other areas, and I think that's something. Those are growth industries for the future that I think will continue to shape the job structure. So we already talked about all this, but I think I wanted to say that in my opinion, global health will be shaped less by medicine, public health innovations, but more by budgets, by boardrooms, including boardrooms of foundations and the private sector, and by ballots, because elections have consequences. And that's why all of these forces at play matter. So I love this quote from Wayne Gretzky, and Jim Kim actually mentioned it a couple weeks ago. We had him at Duke University, and he said how their philosophy was, Wayne Gretzky says that good players skate to where the puck is going, but great players, they skate to where it has. Good players skate to where the puck is going. That's what great players do. Good players go skate to where it's been. And I think that if we apply that kind of mindset to global health, trying to anticipate and understand where we're going, we'll all be better global health practitioners. We'll be and we'll be better collaborators as well. So I think that's it. Thank you very much. No tomatoes. I appreciate it. Yeah.
So really happy to have you. I think we have time for a couple questions.